Okay, good afternoon, everyone in Ethiopia. So we're going to get started with our session today. This is session number 20, and I can't believe that it has been, session number 20 since we started. And I am glad to see a lot of people having logged in to attend this session as well. And as the title says, it's the basic EKG interpretation, but I think there is a lot probably to take for everyone. So our presenter today is Dr. Mikias Ethio-American, who's a staff cardiologist at Washington Hospital Center, which is in Washington, D.C. It is actually one of the busiest cardiac hospitals in the country, from what I remember when I was training in general surgery in Washington, D.C. They did amazing number of heart bypasses and interventions, and clearly he's at one of the very busy cardiology programs, if you will, in the country. Dr. Mikias is a graduate of Harvard Medical School with subsequent additional training in cardiology. So Dr. Mikias can probably give us a little bit more about his background and training and how he wants to actually carry on the session, so that he wants to have some interaction with all of you. And so, Dr. Mikias, the floor is yours, and take it from here.
Okay, thank you for the introduction. I am a non-invasive cardiologist, and it's true, this is probably one of the busiest practices in the country. We do a lot of basic and advanced cardiovascular interventions, including LVAD transplantations, heart transplantations, a number of PCIs per year. In addition to general cardiology, I actually have a training in advanced echocardiography and structural heart disease. So what I want to make sure out of this presentation is that people have a better sense of how to go about reading an EKG. That's probably one of the most important tools that we have in evaluating a patient. I know, well, I think for some of you it might be too basic. For some of you, we may not have dived into the basics enough before we actually review the EKGs. But as I get to know most of you a little bit better and see what your background is, we can tailor a future presentation so that we can address any specific questions that you might have. So what I want to do, after I give you a brief overview of how to review an EKG, I want you guys to chime in to tell me what you think is going on. It won't be of that much use if I tell you off the bat what the EKG shows. Gotta go through, quote unquote, probably the pain of interpreting the EKG yourself. So what I will do is, once I show you the EKG, I'll give you about 60 seconds to look at it and come up with your own interpretation. If you guys could use, let's see if we can use the chat sessions to tell me what you guys is thinking of going on with the EKG, and I'll tell you what is going on afterwards. Okay. And the other thing I wanted to do is, if people could just write in what their level of training is. So if, are you a practicing physician, residents? Is there any cardiologists in there? How many large groups do we have of people? About 5. So if you hear me, please comment on the chat session for the next about 30 seconds.
So the question is, tell us if there's a group of 5. Tell us if you are an attending or faculty. Tell us if you are residents. And what are the additional question?
I think those two are. And if you are a cardiologist, for example, is there a cardiologist?
If you are a cardiologist, so go on the chat session and type in your answers. You can say, I am a cardiology resident, I am a staff cardiologist. We are 3, 2, 1. This is just to have an idea and a sense of, so we have some residents, we have
emergency and critical care physicians, very good. Practicing.
care.
Okay, resident in internal medicine.
Dr. Wendosen is an infectious disease specialist.
Okay.
There is an internist in private practice.
Okay, so there's a person who raised their hand. Should I give them the?
No, I would not raise. I would not give the mics because it will be, it will create a different,
Internal medicine residents. I am residents. Okay, internal medicine residents, emergency and critical care resident. This is fantastic. Okay. 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 Perfect. So
the next question is, are you more than one person? If there are more than one person, could you just tell us how many are you keeping a social distancing? We just want to make sure we don't have big crowds. Is there anyone who is more than 5? Just 1, okay. And any cardiologist in the house? Other than Dr. Mikias? Yes, so there is 1.
okay, perfect.
Okay. You got the sense now?
Yes, very good. Okay, so I tailored this EKGs, by the way, to internal medicine residents, and I guess it would work very well as well for emergency medicine residents and the critical care physicians. And if the cardiologist has anything important to say, please let me know, and I'll transmit your comments from the chat session. Okay. So hopefully people have looked at some of the first initial pages of the book that I have sent you. It's probably the most important book that we have as cardiologists for reviewing and learning EKGs. So when you go to interpreting an EKG, I think you should develop the habit of going through the EKG systematically rather than trying to jump to the most important diagnoses, because it's very easy to miss subtle findings that could be of major clinical importance. And what I usually do when I start reviewing an EKG is trying to decide what the rhythm and the heart rate is. And in order to identify the rhythm, first I look at the P waves, the QRS complexes, what the relationship between the P and the QRS complex is. And in order to determine rate, there's a couple of ways you can do this, okay? One, if the rhythm is regular, then you can use the RR interval and count the number of big boxes that you have to determine what the actual rate is. So for example, each box is basically 200 milliseconds, right? So if the RR interval is separated by 200 milliseconds, that's a heart rate of 300, 150, 100, 75, 60, because if it is 5 boxes, it's 1,000 milliseconds, which is 1 second. So the heart rate is 60. So 300, 150, 100, 75, and 60. The other trick that I use is, so the EKG strip is a 10-second strip. So I count the number of QRSs that are within the strip and multiply them by 6. So in this case, I do 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 60. So whichever way I go, the heart rate comes up to 60. You need to determine the QRS axis. Usually a normal axis for a QRS complex is a positive deflection in lead 1 and FEF, which is what you see here. You need to determine the presence of ventricular hypertrophy versus, and as well as atrial enlargement. You need to look at the ST segments for repolarization changes that could be of a number of clinical scenarios. And finally, obviously, the reason why we do an EKG is to come up with a clinical diagnosis, because we are using it to care for patients, and you need to come up with a clinical diagnosis based on the EKG, okay? So, the intervals on an EKG each of them represents a different part of the conduction system. And they have specific durations through which the conduction passes through that structure. So for example, a P wave duration, the P wave is basically what signals the atrial depolarization, should not be greater than 100 milliseconds or 2.5 boxes longer. The PR interval is where you see the conduction of the electrical signal through the AV node, and it's usually between 120 and 200 milliseconds. The QRS complex basically denotes the initial depolarization of the left ventricle, and usually that duration is less than 110 milliseconds, but there's an intermediate value of 110 to 120 that is what's called incomplete bundle branch block. And finally, one of the most important sections of the EKG is the duration of the repolarization of the ventricle. QRS is depolarization, and the QT interval is the repolarization of the ventricle. And that's usually around 450, whether you are a man or a woman. There's give or take about 10 milliseconds. So the other important thing is how you actually place the leads while you are doing the EKG is very important, because abnormal lead placement can give you a very abnormal looking EKG in a normal patient. So, and I'll tell you specifically, besides the limb leads, which are a little bit more straightforward as to where you're going to put them, for the precordial leads, the first V1 is placed to the right of the sternum in the fourth intercostal space, and V2 is placed right on the opposite side of the intercostal space in the fourth intercostal rib space. So then what you need to know is where to put V4 next, and V4 is one down into the fifth intercostal space, and you place V3 in between V2 and V4, okay? And V6 is in the horizontal mid-axillary line of the patients, and V5 is basically where you put between V4 and V6. And the reason why I stress on that is actually, so I'll show you this. This is one of the most common EKG questions that I get from non-cardiologists. So if you look at the automatic EKG interpretation that comes from the machine, this says sinus rhythm, old anteroseptal infarct. And the reason why that is because you don't see any significant R wave in V1 and V2. And the reason, most of the time, the reason why this comes up is because these EKG leads are placed higher than where they need to be, okay? So this is sent to me because somebody thinks that the patient that they are taking care of has had a major heart attack in the past. And I talk to them and I say, oh, have you had a heart attack? Do you feel short of breath? Have you had chest pain? And they say, oh, I'm completely fine. I do sports and I do everything that I want to do. So, and most of the time, the reason for this is because the EKG leads are placed higher than where they need to be, okay? So everybody's following. If you have any issues, just type it on the chat section and I will try to slow down or give further explanations, okay? So if you look at the first page 5 to 20 of the book that I have sent you, it gives you various criteria for diagnosing left atrial and right atrial abnormalities. These are very important surrogates in making clinical diagnoses. So for example, most patients with pulmonary hypertension have abnormalities in their right atrial size, and therefore something to look out for when you are evaluating a patient with shortness of breath. So if they have right atrial abnormalities or right atrial enlargement, it could be a sign of pulmonary hypertension. And another important diagnosis or findings that you need to look for when you are looking at an EKG is ventricular hypertrophy. There are a gazillion ways of or criteria for diagnosing left ventricular hypertrophy. The most common one that I use is what's called the Sokolov criteria, where if you add the S wave in V1 and the R wave in V5 or V6 coming up to be greater than 35 millimeters. And another criteria is the amplitude of the R wave in AVL being greater than 11 millimeters, okay? And remember, usually left ventricular hypertrophy comes with various additional findings, such as a little bit of a widening of the QRS interval. There is usually associated ST and T wave abnormalities. There is left axis deviation, and this patient also have left atrial abnormality. So we're gonna go into the fun stuff now. So this is actually a patient that I saw last week, and I'm gonna see if you guys can help me figure out what I should do for him. So the man is a 39-year-old man. He's admitted with syncope. He has a history of drug abuse, notably opioid pain medications, and he is placed on a drug called methadone to help him stay off of abusing opiates. This is a common drug that we use here in the US to prevent relapse of these patients. And initially, everybody thought that he had abused drug again, and that's why he lost consciousness. But his urine toxicology test was positive only for marijuana or cannabis. He didn't have any opiates in his system. And his echo showed an EF of 25 to 30%, okay? So I'm gonna show you the EKG, look at it for about 60 seconds, and you tell me what the major findings are. Okay, time starts. And don't worry, there is, I mean.
So, yeah, so we're not going to call names. So just you can type in your thoughts in the chat section, what you see and what you suspect.
Is there an official timer we can have on this, or should I use my phone?
I think you can just use your phone and,
okay.
Or I can help you keep the timer. So you want a few seconds? 20 seconds or something, 30?
30 seconds, okay. 30 seconds is probably a little bit short, but let's give them a minute for this one, so another 30 seconds.
Okay, so remember there's, maybe you wanna, there's no one typing yet, so maybe you wanna give a little hint so that, people can.
Okay, so look at the QRS and the QT intervals and let me know what you guys think.
Start video የሚለው ጋር ኤርፎን ከዛ ኮል ዊዝ ምናምን ነገር አለ።
So let's see, there's one person, there's someone said it's a bradycardia. There's another person probably typing.
Bradycardia, I love it. Okay, thank you. We're on the right.
Yeah.
Yes.
Yeah, Brady, rate of 50.
Yes, you are right. The QT is interval.
Wide QRS.
Yeah. The QRS is actually within normal limits. It's about 80 to 90 milliseconds. Sinus bradycardia with very prolonged QT, okay? So this is actually very scary. Look at this. So if you look at the QT interval, so I told you each of them are about 200 milliseconds, right? So the QT probably ends here and starts here. So it's about 600 milliseconds, 200, 400, there's about 100 over here, or let's say 50, and there's 100 to 150 here. So there's sinus bradycardia with very prolonged QT, okay? So when you have time, read about actual QT and corrected QT measurements. The corrected QT measurement is a little bit less than the actual measured QT in this case because the heart rate is bradycardic. And so you look at this and say, wow, did this guy faint because he had prolonged QT and associated ventricular tachyarrhythmia? Because he obviously was not using drugs, so it cannot be the case, right? So I look at this and I'm like, okay, something bad could be happening. Then, so there are two possibilities when you see prolonged QT, right? One is that, yes, and the person said poor R wave progression. That is correct. I second that. Basically sinus bradycardia, old anteroseptal infarct, prolonged QT, and there is non-specific STT changes. So when I look at the prolonged QT and I say to myself, why does he have prolonged QT? Is it congenital or is it acquired? Okay, so then what do I need? An old EKG. This is this EKG from 2015, about 5 years ago. Okay, so what do you guys see? Another 30 seconds. Or what do you think about the QT interval here? Anyway, normal or abnormal? You can type that. So normal QT or abnormal? Normal, okay, normal. I love this, okay. So it's a normal QT, you're completely right. So something must have happened between 2015 and 2020 for this guy's QT to expand from normal to very, very, very long, right? So it cannot be a congenital because it's not going to wait until he's 39 before the QT prolongation shows. And there is a list of channelopathies that causes QT prolongation. And those are the things that you remember for an exam and immediately forget, just like the Krebs cycle. So I'm not going to go into that. But the main reason why I think this guy's QT prolonged is because of something that has happened to him. And there is a very known offender, which I'm sure you guys don't use in Ethiopia, but the reason why his QT prolonged is because of methadone, okay? So now this guy is in a very tough spot because if I stop the methadone, that's like life to him because he's gonna start using opiates again, and opiate drug abuse is basically a death sentence for most people. So what do I do? If I give him the opiates, his QT is gonna get prolonged again and possibly die. And if I withhold the methadone, he is gonna likely go into a bad spiral and die at some point early. So the person is still in the hospital, but this is what I think is going to happen. So what I did was I halved the dose of his methadone and started checking daily EKGs, and the QT has stayed normal. And the good thing is he could potentially have down the line an indication for a defibrillator because of his low EF. So we're gonna wait at least 3 months probably before we implant a defibrillator. But in the meantime, there is what's called a life vest, which is a jacket type of defibrillator that people wear on and off. It kind of works. It doesn't work very well. I don't like it that much, but in this case, it's probably appropriate. So that's probably what's going to happen to him. He will get a life vest before he leaves from here. He'll get very frequent EKGs while he's on a reduced dose of methadone, and hopefully he will do okay. But this is a very, very tough choice. Okay. So, and remember, there is a number of drugs that you use in your daily practice that causes QT prolongation, which you need to watch out for. There are antiarrhythmics such as amiodarone, antibiotics, antidepressants, antipsychotics, Haldol, and others that you need to watch out for when starting patients on this medication. And I'm not suggesting that you do daily EKGs for a person who has levofloxacin, but at least if there is a clinical scenario such as this, you should think about QT prolongation as the cause. And as you can see, methadone is one of the list of drugs that is listed. Okay, so what is this? And what is this and what's the treatment, I guess?
Okay, timer is on.
Torsades, okay. Somebody has said the diagnosis. Yes, that's correct. This is torsades. So if you have QT prolongations, this is what it will lead to. It's actually a French word, torsade de poids. So if a person is unstable, so it's actually torsade, not polymorphic VT. What do you do if the person is unstable with this rhythm? So you have a person with very low blood pressure or non-palpable pulse. Okay, magnesium sulfate, cardioversion. Okay. Yes, not cardioversion, defibrillation. There's a difference between cardioversion and defibrillation, right? If a person is unstable, the first treatment is to defibrillate. Correct atropine, especially, and also magnesium sulfate is the correct treatment, adjunctive treatment, and you can do it if a person is stable. But if a person is unstable, you need to defibrillate. And there's a difference between defibrillation and cardioversion, okay? Cardioversion synchronizes with the QRS of the person's beat before delivering a shock. The risk of not synchronizing is what's called an R-on-T phenomenon, which means that if you deliver a shock to a person while the ventricle is in depolarization, you actually could send the person into ventricular fibrillation. So you do cardioversion for a stable patient or a non-complex rhythm where the machine can actually synchronize, but with this, the machine cannot synchronize. It will just deliver a shock wherever. And most of the time, it should work. So the treatment, the additional treatments beside defibrillation for a person who's unstable includes atropine, magnesium sulfate, isoproterenol. And the other thing is we actually do overdrive pacing for this. We put in a temporary pacemaker and start to pace the person at a heart rate of 110, and that works too, okay? So this is torsade de poids, and this is what could be the result of a prolonged QT. Okay, so so this is, you know, a real scenario that you might face. So let's say this is a 25-year-old male athlete of Ethiopian Olympic team who faints while training. What is going on? So tell me what the findings on the EKG is and what the clinical diagnosis is.
I will call a cardiologist.
That is a very fair answer.
So you're getting some answers there. ST elevation, HCMP, left ventricular hypertrophy, hypertrophic cardiomyopathy.
Okay, so I guess I don't see the answers, but
I see a lot of inverted T waves here, so it is
okay. So 16. Let me see if I can scroll down to see if I can see the answers. Right. So CMP strange pattern, diffuse T wave inversion, well and sign. Okay. Deep narrow Q waves. All excellent answers, by the way. Okay. So the one thing that I want to tell you about medicine in general, the way I view things, is to know when something is very abnormal and you need help, and when something looks relatively benign and that you have time to wait, right? So you're right, there's something funky going on when you look at this EKG. So if you don't know exactly what's going on, you better call someone that knows what they're doing, right? So calling for a consultation is very appropriate. So you guys have actually gotten the diagnosis right. It's hypertrophic cardiomyopathy. But what I want to caution you against is the first thing is mentioning the EKG findings and coming up with the clinical diagnosis right at the end, right? So this is sinus rhythm, okay? The most profound finding is that there is LVH, okay? There is repolarization abnormalities. There is deep symmetric T wave inversions, septal Q waves, which is all pathognomonic for hypertrophic cardiomyopathy. Somebody said Wellens sign. I think if you look at the T wave in isolation, maybe you can, but remember, the Wellens sign is basically an EKG that is indicative of proximal LAD occlusion, right? So this is a 25-year-old male patient. I know there is a lot of early atherosclerosis that we see, especially in Africa and the in the Indian subcontinent, but it's pretty much unusual to have a proximal LAD occlusion in a 25-year-old, okay? And if they fainted because of a proximal LAD occlusion, there is some other sign that you will see. That is a good comment. So this is consistent with what's called hypertrophic cardiomyopathy, okay? And the EKG findings is what I told you, and echocardiogram is needed for diagnosis, and we do actually cardiac MRIs in the US as well for various prognostic reasons. And the main thing that you need to know is that, first of all, he can't go and run a marathon. So you cannot let him participate in competitive sports. And you need to consider an ICD. In his case, it would be for secondary prevention, which means that he has had an event and he's getting it to prevent the second event, what the secondary prevention is. But you need to consider ICD for primary prevention as well in patients who have had a family history of sudden cardiac death. And there are some other echocardiogram findings, such as a septal wall thickness greater than 3 centimeters or 30 millimeters. So I think in the future we can set a lecture just purely on hypertrophic cardiomyopathy, but I just wanted to give you a flavor of what the EKG looks like, okay? Okay, so next. So this is a clinical scenario, an 84-year-old woman who presents to the ED with a crushing chest pain of about an hour, tachycardic, hypotensive. There is S4 and S3 gallops. There is lung congestion and cool extremities. And this is the EKG. So tell me what the major findings are.
Okay, timer is on. So do you get EKS when this kind of patients come to the emergency department? Would they reach out to you on your phone or something with the EKG? Is that something that happens at the hospital center, or do you have to go in to see this?
Interventional cardiologists, so they bypass the general cardiologist. They go straight to the interventional cardiologist.
Okay, so you have some answers there. I don't know if you can see.
EF, unstable, shark fin, LADMI. So there is anterolateral ST elevation with reciprocal ST depressions in the inferior leads, okay? And what is this? Non-sustained ventricular tachycardia. So this is not VF. This is, so there is more than 3, so it has to be NSVT. So there is PVC, couplet, triplet, Then above that, you have to call it non-sustained ventricular tachycardia. So there's another rhythm abnormality called AIVR, accelerated idioventricular rhythm, which is actually associated with reperfusion, which is relatively benign. But this is NSVT, sinus tachycardia with anterolateral myocardial injury. So I'm going to ask you a question again. So this person's symptoms started A, 1 hour ago, 2, 8 hours ago, C, 48 hours. So I'm going to give you 1 hour, 8 hour, or 48 hours. Which one is the answer? 1 hour, okay. Do we have another answer? 8 hours, okay. And just out of curiosity, the person who said 8 hours, why did he say that? Oh, the question is, if you were to guess if the symptoms started an hour ago, so the person developed chest pain, A, likely an hour ago, B, 8 hours ago, C, 48 hours ago.
And you're saying if you say 8 hours, why are you saying 8 hours?
Eight hours, okay. Okay, so if it's 8 hours, you're correct. Well, that's what I think. Because if it is just 1 hour, you don't see the infarct pattern starting to happen. So this person has started developing Q waves, right? And if it is 48 hours, the MI has evolved where you start to see aneurysmal changes, and the ST segments will definitely resolve by then or significantly lower. So the fact that the person has started developing Q waves already, you are probably outside of the first 1 or 2 hour window, okay? And the treatment for this is basically reperfusion therapy. And in the US, this happens within minutes of the patient presenting to the hospital. And it doesn't matter if it is a holiday, if it is at 3 a.m., if it is at 7 a.m. in the morning, if it is at 3 p.m., there is somebody and a team waiting in line to treat this patient as early as possible. And if the time from this EKG to the time that the interventional cardiologist opens the clotted artery is more than 90 minutes frequently, the hospital gets penalized, okay? So the other question that I wanted to ask you is, you don't want to give IV metoprolol for this patient. Why? Yes, so the person is in shock. So not every patient with acute MI should be getting beta blockers. And in this case, what's worrisome is the fact that the person is, which is an indicative of a low output state, okay? There is cardiogenic shock with hypoperfusion of organs, which is different from high filling pressures with normal cardiac output. So you can have a cardiogenic shock with normal cardiac output, but high filling pressures, and you can have low cardiac output, which is very, very concerning in this case, and indicative by the cool extremities. So how far are we into our timing? Okay, I need to go a little bit more quickly, okay? So a 45-year-old man with chest pain. Cath lab or no cath lab? Type yes or no. If you want to send him for angiography, say yes. If you don't want to send him for angiography, say no. Yes, okay. We'll have a yes. Do we have a no? Yes, no? I need to see a couple answers first before I give you the answer. Yes. Yes. Okay. this is a definite no, okay? The reason why that is this is actually not ST elevation due to myocardial injury. This is early repolarization, and this is indicative by this notch that you see here, which is what we call a J-point elevation. So not all ST elevations are actually concerning, okay? There are some benign ST segment changes, and these are actually fairly frequent in African-American men and Black men, okay? Okay, I guess we learned something. That's good. Okay, so I'm gonna keep this EKG. I think we are, so this is an EKG for a patient, okay? And the person, okay, so look at this EKG. So the person is coming in with chest pain, okay? You look at these in the inferior leads. Okay. So the nurse tells you, can we please give this patient nitroglycerin because he's having crushing chest pain and ST elevations. What do you say? Yes to nitroglycerin? No. Yes, so I didn't tell you that he had typical chest pain. You're right. So there are some EKG silent MIs. So if the person is, I mean, there is a whole different types of reasons why a person would have chest pain. Okay, so the question is, so you said inferior MI, the nurse asks you to give nitroglycerin to this patient, and your answer is yes or no? No, yes, okay, no. That answer is no, you are correct. So nitroglycerin to inferior wall MI is contraindicated. This patient, if they present with hypotension, the first thing you need to do is give them fluids, okay? Yes, it worsens hypotension, exactly, perfect. Okay, we're onto something here. So you need to know what the clinical triad for RV infarction is, which is hypotension, clear lung fields, elevated JPP. And actually, RV failure is one of the most interesting. I have a case that I will present to you guys at some point. Okay, so this is an EKG that I have deleted. This is a lateral wall MI. Okay, so ST elevation in the in lead 1 and AVL, which is usually the circumflex territory. I'll skip this. Okay, this is interesting. Okay, what's going on here? So this is a 52-year-old man with chest pain. I didn't tell you what kind of chest pain it is. He just says, I have chest pain, and you see you're given this EKG. What is the diagnosis? And right to the diagnosis, pericarditis, okay, you are correct. So there is diffuse ST elevation, okay, with PR depression in all the leads except an AVR that shows a PR elevation, okay, pericarditis. Okay, what's the treatment for this? Right, the 2 drugs that we need to use to treat this patient. For the first line treatment. NSAIDs plus what? No steroids, no. Unless the person is not able to take NSAIDs, steroids is the wrong treatment because it increases your chances of having recurrent pericarditis. Yes. So the first line of treatment is NSAIDs plus colchicine. Colchicine for 3 months because it reduces recurrence. And if you give them steroids, it is because they cannot tolerate NSAIDs. If they have a history of GI bleed, if they have allergic sensitivity to NSAIDs, you can give them steroids. But steroids is not the first line of treatment, okay? Okay, so, so this is acute pericarditis. This is an interesting one, okay. So, yeah, there might be a prize for a person who tells me this diagnosis. What is this? Alternance, exactly. Okay, so which is an indicative of pericardial effusion. And does the person has tamponade physiology based on this EKG or no? So somebody said tamponade. That was a trick question. Okay, so you cannot tell me from an EKG that a person has tamponade physiology. The reason why this happens is because the heart is swimming from one direction to the other in the pericardial sac, and that's why the voltage changes from one beat to another. But echocardiogram, tamponade is a clinical or an echocardiography diagnosis, depending on which side you are on. But you need either pulsus paradoxus or echo findings of tamponade to diagnose tamponade physiology. And I actually have an echo that I can show you guys next time about for tamponade physiology. So the treatment for this is pericardiocentesis. Okay, you want to take out the fluid. Okay, so how about this one? VTAC, okay, we have a good answer here. Any other attempts? VF, okay, PVC. And I want to say actually, thank you all for actually trying to do this. This is good. I know it's very easy to just stay quiet and listen, but left bundle branch block pattern. Okay. Okay, so by the way, I'm going to give you a clinical scenario for this. This is a 55-year-old guy with stage 5 CKD who comes in with several symptoms. Tigges Tesfaye. Okay, so Tigges, Dr. Tigges, if you could tell me your training level, I'm curious. Emergency medicine, and you are a practicing physician? Okay, so you are 100% correct. This is absent P waves, wide QRS, peaked T waves, which is all consistent with hyperkalemia, okay? You need to memorize this EKG and the findings. It's clinically very, very important. So diagnosis is hyperkalemia, and the initial giveaway to this is the peaked or tented T waves. And hyperkalemia, depending on where the stage is, can do a whole lot of things to an EKG, okay? The P wave amplitude is completely gone. The PR interval prolongs. The QRS widens, just like in this case. You kind of have sinoatrial block. You can have a lot of STT changes that look like this is acute MI. I think somebody said acute MI, so I'm not mistaken. So, and there's a lot of conduction blocks, and this could degenerate into ventricular fibrillation, okay? So, what's the treatment? When you see this, there's one drug that you need to give the person as soon as possible. Calcium gluconate, yes. You can't wait until dialysis. The first thing is you need to stabilize the cardiac membranes using calcium gluconate. And there's probably a number of other things before you hook them up with that you can do faster than hooking them up on dialysis. They need some sort of a way to pee out or dialyze the potassium, but you can give them K-oxalate, you can give them insulin and glucose that is going to, yes, intravenous insulin to shift from extracellular into intracellular. You can give them albuterol, actually, okay, beta agonist. Very, very good, very good. So this is great. I'm very impressed. Okay, Mel, you can tell me when to shut up, okay? I think we're approaching time. Okay, so this is an EKG of a 52-year-old woman with shortness of breath, okay?
So Mikhail, we have about 10 minutes, so.
Okay, I think I'm gonna probably try to finish before then.
Okay.
30-degree AV block, 30-degree AV block. Okay. But I can tell you that there is.
Third degree, no, third degree.
It's a third degree, yes. I know. Again, there is a PQRS relationship. At least these P waves are conducted, I think. So there is no dissociation between the P and the QRSs, at least completely. You're right. There is this P waves that are not conducted. Okay, so somebody said second degree Mobitz type 2. Somebody's getting closer, Mobitz type 2. Not quite, but I'll tell you, hypokalemia, not necessarily. Nope. So the people who got close to it is the ones that said second degree Mobitz type 2, but no. So when you look at this EKG, the only thing you can say about it is there is sinus rhythm with 2-to-1 AV block, okay? Blocked, conducted, blocked, conducted, blocked, conducted, blocked, conducted, blocked, conducted. From this, it can be either second degree Mobitz type 1 or Mobitz type 2. The only way you can differentiate between the two is by trying to increase the atrial rate and see what happens to the conduction, okay? So if you increase the atrial rate, you can have a conduction pattern where there's conduction, prolongation of the PR interval, conduction, then drop, or you can have this abrupt drop of the P waves without PR prolongation, which would be second degree Mobitz type 2. So from this, what you can tell is sinus rhythm with 2-to-1 AV block, and you cannot say whether this is Mobitz type 1 or Mobitz type 2. In order to do that, you have to increase the atrial rate somehow by having the person walk or telling them something that upsets them and see what happens to the atrial conduction, okay? Okay, so this is important. 68-year-old woman with dizzy spells.
There is some block going on here, huh?
Yes. Sick sinus syndrome, very good. There is sick sinus syndrome. What are these beats? What are these beats? So these, so there's a P wave here, right? Probably a prolonged PR, QRS. And I see this. I mean, I don't see any P wave here. P, QRS, no P, QRS, P, QRS, no P, QRS, P, QRS. Junctional escape, yes. So there is a sick sinus syndrome with a junctional escape rhythm. And you might think that the QRS complexes with this and this are the same, but they are not. I think, yeah, maybe this won't prove the point, but at least if you think that this is part of lead 3, this QRS and this QRS look completely different, right? Okay, so the person has sick sinus, sinus bradycardia with junctional escape rhythm. Okay, so I'm gonna show you just one EKG and we'll stop. What is this? Hey, what does this look like? Getting close. This looks like a saw, right? Magazi masla. Yes. This is atrial flutter. What is the conduction? Is it 2-to-1, 3-to-1? Not VF, this is atrial flutter. So VF is, I mean, it doesn't have a, this looks like a regular pattern, right? VF looks like some chaotic rhythm. Uh, 3-to-1, okay. It's actually 2-to-1. So basically atrial flutter goes at a rate of 300 beats per minute in the atrium. Yes, 2 to 1. So, and if it is a heart rate of 150, it's a conduction of 2 to 1. If it is 100, it's 3 to 1. If it is 75, it's 4 to 1. So this is 300, 150. So, you know, if you see a heart rate, a narrow complex heart rate of 150 in a person probably above the age 50, it's likely atrial flutter by statistics, okay? Okay, so this is what happens if you do a carotid massage. So carotid massage basically lowers the conduction through the AV node. Now there is probably a 3 to 1 conduction. The heart rate is about 100. You can clearly see the flutter waves. I think you have a lecture coming up next Friday about atrial flutter. You can learn more about the management and the treatment. Most of these people we ablate, but yeah, I think probably that is a good place to stop. Any questions? And
Well, thank you, Dr. Mikias. I mean, this was a wonderful review, and we experiment something new today, and I think we kept our audience engaged, which is fantastic. And I think we'll probably end up doing more of this. So, did you want to comment on additional things, or are you done?
I am done.
To take a few questions.
Comments.
So, if there are any specific, couple of questions, maybe this is a good time to ask so that we can wrap up. And I did not see if Dr. Henok is online. Dr. Henok, are you there? Do you want to add anything? Any comments? Or Dr. Tesfaye? Are you?
Yeah, Dr. Gurma, I'm here.
Okay, go ahead, please.
Can you unmute me?
Yeah, we can hear you. Go ahead.
Dr. Mikias, the fantastic cases, great cases. I just wanted to say that these are very important cases, and with EKGs, obviously, there are pattern recognition EKGs that we can just have to memorize, have to know about them as a trainee. There are also EKGs that we can't afford to miss. And I just wanted to emphasize that PERSAD, the polymorphic VT EKG, it was very, very important to know how to manage that the difference between defibrillation and cardioversion. Also the need for transcutaneous pacing, because these are rate-related bradycardias related polymorphic VTs. So if you don't have isoproterenol in an Ethiopian setting, if you don't have the temporary wire, you can put a transcutaneous pacing as well, and also avoid any drugs that can slow the heart rate. The hypertrophic cardiomyopathy EKG was fantastic. Again, you can't miss those young patients who come in with syncope, because there is absolutely great management to that. The Wallens sign question, I'm an interventional cardiologist, so I see that all the time. The Wallens T waves are biphasic T waves, unlike the deep inverted T waves, symmetrical T waves in hypertrophic cardiomyopathy, particularly in the apical variant of hypertrophic cardiomyopathy. So Wallens T waves are biphasic, and that, like Dr. Mikias said, that is a sign of anterior stem, most commonly because of proximal LAD, the occlusion. Anterior MI, all MI ST elevation EKGs look for reciprocal changes. Really, if you have a big anterior tombstone ST elevation, that's clear, you know that. However, not every ST elevation needs a cath lab activation. Clearly, when you have diffuse ST elevation, that is mostly pericarditis, but always look for reciprocal changes. Inferior ST elevation, look for AVL ST depression, lateral ST depression. If you have anterior ST elevation, look for inferior reciprocal changes. So those are very important things. And that patient that Dr. Mikias presented was very sick. That needed perfusion, obviously, and also mechanical circulatory support, most likely. So, those are a few of my comments. Otherwise, it was a fantastic session. Thank you.
Thank you. Dr. Henok, are you on the line too, or? maybe working. Okay. Because I don't think there are any additional questions, and any pointers towards, you know, the book, what people should do, and how you recommend deepening the knowledge on the EKG issues. And I just want to say thank you to also the wonderful book you sent along to everybody.
Okay, so I'll tell you this. One, learning EKG is a humbling process, okay? So unless you are willing to put your pride aside and are willing to make mistakes, it is hard to sort of progress your knowledge. So let your guard down. It's okay to make mistakes. And the main thing is to get better as you go. And the second thing is, I want to hear back from you. I want to hear from the people who are attending what works for you, what doesn't work for you. And then we can refine our sessions so that, you know, you're not just wasting your time. The EKG book that I sent you, I wouldn't necessarily start studying EKGs from that book. It is very, very difficult. But if you feel like you have gotten the basic EKG skills down, you can start to look at it. But the EKGs are very, very tough.
Great, and you know, thank you so much again, and we'll have you help us maybe put together with Malaku some survey questions later on to really understand, you know, about, you know, the sessions that have been done already and where the gaps might be, so that, you know, when we come back at some point, we can actually do improve based on the feedback. So we'll encourage them to do that. So please, everybody, join us again on Friday. The continuation, we're going to be still talking some more about arrhythmias, and I think with some emphasis on AFib and flutter. You know, this was really a wonderful session today. I just want to say thank you to my presenter here, and see you all again on Friday. Thank you.
Thank you.
Thank you.